Another cranial nerve. We've looked at some cranial nerves which are purely sensory. We've looked at some which were somatic motor and visceral motor combined, the oculomotor. We looked at some which are somatic motor and sensory combined, the trigeminal. Now we are looking at the mother or father of all cranial nerves. This is the most complicated cranial nerve that there is. The facial nerve, it has everything you can conceive of. Somatic motor, visceral motor, every kind of sensory, including taste, which is considered a special visceral sensation. And it has an extraordinarily complicated pathway as well. Going to do it is, I guess, a modification of a diagram that's in core, but so I'm going to trace out every branch of the facial nerve and things with which it is associated, and then we will fill in all of those with the kinds of axons or functional kinds of axons that are carrying it. Now, this is meant to be here the entry to the internal auditory meatus. As you know, comes a hole in the back of the petrous temporal and the posterior cranial fossa. The meatus itself is about 1 centimeter long. It's a fairly wide canal within the petrous temporal, and it ends at a bony wall which has a much smaller exit foramen from the internal auditory meatus into the petrous temporal, further into the petrous temporal. Now, entering the internal auditory meatus, as you know, are 7 and 8. I've not drawn 8 in here. That's not the topic for today. It would be next to this thing called the nervus intermedius. It's so hard to see in dissection the 3 nerves which go through the internal auditory meatus. 2 of them are actually part of the facial nerve. The 2 I've listed here, the somatic motor root and the nervus intermedius. And the other one, the vestibulocochlear, obviously sits next to nervus intermedius, but it's so hard to find 3 clear nerves going through there the way we remove the brain. Anyway, somatic motor root of the facial, nervus intermedius that come out of the brainstem at slightly different locations, travel independently towards the internal auditory meatus, enter the internal auditory meatus, and right near its termination, they join one another. And when they join, they form the facial nerve, the definitive facial nerve. And that definitive facial nerve passes through a tiny hole at the end of the internal auditory meatus, which takes it into a much narrower channel, narrower than the internal auditory meatus, within the actual petrous temporal itself. So here is the facial nerve now in that narrower channel, which is called the facial canal. That narrow channel within petrous temporal beyond the internal auditory meatus is called the facial canal. So the facial nerve forms in the internal auditory meatus and enters the facial canal within the petrous temporal. And it takes a little course that curves anteriorly ever so slightly. You'll see this when we actually dissect this on the last day of head and neck dissection. And after traveling maybe, 4 or 5 millimeters in this facial canal, the facial nerve bifurcates and sends off one branch anteromedially and a much larger branch posteromedially. And because the larger branch, and this is all occurring just at the point where the bony medial wall of the middle ear cavity exists. That bony medial wall of the middle ear cavity is referred to as either the medial wall of the tympanic cavity or the labyrinthine wall, because in this part of the petrous temporal, it's also not just this branching of the facial nerve, but it's also the semicircular canals and cochlea and things like that. And that's considered the labyrinth. That's what your labyrinth is, so this is called the labyrinthine wall. So anyway, when it reaches the medial wall of the tympanic cavity, it bifurcates into a small branch anteromedially, a much larger branch posterolaterally, and the large branch retains the name facial nerve. So as a result of that, this thing right here, what I'm pointing to, is a bend in the facial nerve. Because it had the name facial nerve as it approached the medial wall of the tympanic cavity, and now the large posterolateral branch keeps that name, so this now is a bend in the facial nerve. And the small branch, which heads anteromedially, changes its name. It's not called the facial nerve anymore, and that's called the greater petrosal nerve. So the greater petrosal is considered a branch then of the facial nerve. The bend in the facial nerve is, like many bends in the body, is called the genu of the facial nerve. Okay? Same root word as knee. Genu refers to knee. Genuflect is to get down on bended knee. This is the genu or bend of the facial nerve. The facial nerve continues posterolaterally in the medial wall of the tympanic cavity, and when it reaches the back part of the tympanic cavity, and I can't really draw this in the schematic diagram correctly because it's running posterolaterally and then it dives inferiorly. It takes a 90-degree turn and runs inferiorly, so this is meant to be an inferior turn, and that bend where it turns and heads 90 degrees inferiorly, this time in the posterior bone that forms the posterior wall of the tympanic cavity, that's often called the second genu of the facial nerve, the second bend of the facial nerve. And it runs in the posterior wall of the tympanic cavity, giving off two nerves into the tympanic cavity, one called the nerve of the stapedius, we'll talk about what these do later, and the other called the chorda tympani, a name you are familiar with. And it travels down then, what is a continuation of the facial canal, this whole hollowed out tunnel of bone that this is traveling, and it's called the facial canal. At the very end of the facial canal is the stylomastoid foramen, and you've seen that in your skulls. And the facial nerve then exits the temporal bone finally at the stylomastoid foramen, where it gives off some branches I don't believe I've ever seen in my life, but I must exist because every book talks about them. They go to the posterior belly of the digastric muscle. They go to the stylohyoid muscle, muscles you've seen in dissection. They go to the occipitalis, which is a part of the occipitofrontalis. Some of you saw, but we don't require that you see it. And they go to two of the muscles of that move your ear, the external ear, the posterior and superior auricularis muscles, which I don't care much about either. So all these little branches that are given off right after it exits the stylomastoid foramen go to these muscles of no great consequence, I guess. Posterior belly gastric is of consequence as a landmark, even if it's probably not so important functionally. And then, the facial nerve turns and enters the parotid gland, and that you have seen, and it gives off the 5 branches that we see here. At its point of bifurcation into what's an upper division and a lower division, that is often called the pes anserinus of the facial nerve. Pes anserinus means goose's foot. And a goose's foot is this triangular sort of thing. And we'll come across another pes anserinus when we dissect the lower limb, where some muscles insert onto the tibia. But this triangular zone here, where it divides into an upper and a lower division, is called the pes anserinus of the facial nerve. You'll see why I tell you that later on. Now, let's go back and look at some of these other branches that were given off along the way. The chorda tympani. Chorda tympani actually enters the middle ear cavity. Has a hole right through the posterior wall that leads it into the middle ear cavity, where it passes across the medial or inner aspect of the eardrum, and in fact, medial to there are these two little ossicles you'll see when we dissect the middle ear on the last day of head and neck dissection. One's called the malleus, the other called the incus, which transmit vibrations of your eardrum to your cochlea in that chain. And it passes medial to the handle of the malleus and lateral to the long process of the incus, so it sort of passes in between these two bones across the medial aspect of the eardrum, hence its name, chorda tympani. Tympanum is the eardrum. And then it travels out of the middle ear cavity in something which you don't really have to know about, but which is the name. It's a little suture between the petrous portion of temporal and the tympanic portion of the temporal bone called the petrotympanic fissure. And when it leaves that petrotympanic fissure, that carries it into the infratemporal fossa. Other things entering the infratemporal fossa that you do know about through the foramen ovale is V3. I've drawn here its auriculotemporal branch, not labeled. I've drawn here its inferior alveolar branch, not labeled. And I have drawn its lingual branch labeled. And again, from our dissection, we know that the chorda tympani joins the back of the lingual nerve and is carried with it. That lingual nerve, which we will eventually dissect, travels all the way to the tongue, hence its name. And as it's doing so, passes very close to the submandibular salivary gland and very close to the sublingual salivary glands. And there is a ganglion suspended from the inferior surface of the lingual nerve, which is we'll talk about what kind of ganglion it is, called the submandibular ganglion. And that submandibular ganglion is connected by a branch to the submandibular salivary gland, and the lingual nerve is connected by branches to the sublingual salivary gland. So that's one part of the facial nerve. The greater petrosal branch of the facial nerve exits the petrous temporal and a little slit in the bone called the hiatus of the facial canal and enters the middle cranial fossa, travels towards the foramen lacerum, which in life is filled with cartilage. On the superior surface of the foramen lacerum is where the carotid artery makes one of its 90-degree bends, this one to bring it from the carotid canal of the petrous temporal bone into the cavernous sinus. So it makes a bend right here to enter the cavernous sinus. And that bend sits on the superior surface of the cartilage that fills the foramen lacerum. The carotid artery, internal carotid artery, has this plexus of nerves derived from the superior cervical sympathetic ganglion. These are postganglionic fibers, which form what's called the internal carotid plexus, which travel with the internal carotid artery from the moment it enters the cranium all the way to its termination. But as this internal carotid plexus of postganglionic sympathetic nerves is traveling with it, just superior to the cartilage of the foramen lacerum, it gives off a little branch called the deep petrosal nerve. The deep petrosal nerve, which carries postganglionic sympathetics, joins the greater petrosal nerve and forms something called the nerve of the pterygoid canal, or many physicians still use the eponym Vidian nerve. And the Vidian nerve, the nerve of the pterygoid canal, pierces the cartilage of the foramen lacerum to enter a bony channel at the base of the medial pterygoid plate called the pterygoid canal. And it travels in that bony channel at the base of the medial pterygoid plate into a space, which I hope you know about, called the pterygopalatine fossa. And this nerve of the pterygoid canal then passes through the pterygoid canal into the pterygopalatine fossa, where it encounters a ganglion called the pterygopalatine ganglion. Also entering the pterygopalatine fossa through the foramen rotundum is another nerve, not part of the seventh, part of the trigeminal, V2. So V2 is brought into close proximity to this ganglion, the pterygopalatine ganglion. V2, I've just drawn a few of its branches here and labeled them, the ones you know about, I hope. V2 is in close proximity to the pterygopalatine ganglion and is connected to it by a bundle, which to my knowledge does not have a name other than the connecting bundle between the V2 and the pterygopalatine ganglion. And then from the pterygopalatine ganglion descend some nerves called greater and lesser palatine nerves, which take you to your soft and hard palate. Then also coming from the pterygopalatine ganglion, and this is coming like out of the plane of the blackboard, is a nerve that passes through the sphenopalatine foramen into your nasal cavity. These are nerves, rather, posterior lateral nasal and posterior septal nerves, which are heading into the nasal cavity. And then finally, from this pterygopalatine ganglion is an unnamed nerve or nerves, very tiny, which we will never see, have to be dissected by a dissecting microscope, which pass through the inferior orbital fissure to gain access to the orbit, and where branches are given to the iris of the eyeball and the lacrimal gland. That is the entire pathway of the facial nerve and the things it is connected to. And now let's take a look at what is in each one of these bundles of nerves that we have seen or given names to. The somatic motor axons, which exit the brain in the somatic motor route, and so that is in blue, the somatic motor route, travel in the facial nerve when it's formed, towards the genu of the facial nerve, and they all turn posteriorly to continue with the facial nerve as it's running in the medial wall of the tympanic cavity. And they all, at the second genu, turn inferiorly to travel with the facial nerve as it's running in the posterior wall of the tympanic cavity. And there, a few of them leave and innervate this muscle called the stapedius muscle. The stapedius muscle is a muscle. We will see may see its tendon. You can barely see the muscle. It's almost microscopic in size. But its tendon is actually visible. The muscle is actually embedded in a little, surrounded by a little cone of bone, so it's very, very hard to see. But the tendon of the stapedius muscle attaches to the stapes bone, which is a bone that articulates with the incus here, but it goes and actually is the bone that drives the fluid within your cochlea and causes sound pressures that have been transmitted from the eardrum through the malleus and incus to the stapes to actually cause waves to pass through the fluid within your cochlea. So the stapedius muscle has a tendon which attaches to that stapes bone. And when the stapedius muscle contracts, it dampens the vibrations of the stapes bone. We've already come across another muscle that dampens vibrations of sound. That was the tensor tympani, which inserts on the malleus. And that dampens vibrations of the eardrum itself. But the stapedius dampens vibrations of the stapes, which is actually driving the fluid of the cochlea. And it is thought by most people to be a muscle that protects your cochlea from high-intensity, low-frequency sound. It's most effective in dampening vibrations below 2,000 cycles per second, below 2,000 hertz. As you get to higher and higher frequency, it becomes less and less effective. And it is true that, in fact, if you play loud noises to a person, the stapedius muscle contracts. I mean, people know that. It also contracts when you're speaking, just like the tensor tympani does. I'll talk about what happens if it's not working later. But that is believed to be its function. It doesn't work from a single loud noise. If I were to take a balloon, and well, a balloon is not loud enough. If I were to explode a stick of dynamite next to Thomas, should he survive? He would lose his hearing on that side because it does not protect you. He would lose, not permanently, but it does not protect you against a single loud sound because it takes so long for this muscle to contract and actually do something that the sound has already gotten through. But it's good for repetitive, yes?
How does contraction soften how does
it just pulls on the stapes. It pulls on the stapes and stops the stapes from vibrating as much as it would. An actual physical force on the stapes to stop it from vibrating as much. But for repeated sounds, it's pretty good. So if you're not, you have a jackhammer type thing where it's going, it's not so bad for protecting you for those kinds of things. Yeah.
Will it contract after the big loud noise? Like, is that why you hear dampened sound after?
It can. By the time its contraction actually has an effect on the stapes, that loud noise has already reached your cochlea. That's why I said it's not good for a single loud noise, but it's good for. But then if you have a series of them, the first one gets through, but all the others are prevented from getting through in their full intensity because it will then stay contracted. It does not protect you really from damage to your cochlea for high frequency noises. So if you go and not that you would ever listen to rock and roll bands because I know you're much too mature for that, but should you do that, all that noise that those guys play on their high-pitched guitars will eventually make you deaf. All right. So that's the first branch carrying somatic motor axon goes to the stapedius. Then all the other somatic motor axons continue inferiorly. They go past the chordae tympani. They have nothing to do with it. They exit the stylomastoid foramen and are distributed through these branches of the facial nerve distal to the stylomastoid foramen. There are parasympathetic preganglionic axons which have exited the brain in the nervus intermedius. And those parasympathetic preganglionic axons then join the facial nerve when it is formed, and they travel towards the genu of the facial nerve. And some of those parasympathetic preganglionic axons turn and pass anteromedially in the greater petrosal nerve, and others of the parasympathetic preganglionic axons continue in the facial nerve past its genu. Which ones am I going to trace next? I guess I'll trace the ones that continue in the facial nerve. They pass down, and they continue past the second genu into the part of the nerve that's in the posterior wall of the middle ear cavity, and then they all leave in the chordae tympani. And they travel across these structures of the middle ear I mentioned, exit through the petrotympanic fissure, join the lingual nerve. The chorda tympani brings them to the lingual nerve. And now they're running in the lingual nerve along with all of those trigeminal fibers, which are running in the lingual nerve. And they travel with the lingual nerve down to the site of its proximity to the submandibular salivary gland, where they synapse on the postganglionic parasympathetic cell bodies, which make up the submandibular ganglion. That's what it is. It's a postganglionic, made up of postganglionic parasympathetic cell bodies. And the postganglionic axons themselves leave the submandibular ganglion, and some travel down to the submandibular salivary gland to cause it to secrete. Others rejoin the lingual nerve and are carried with it further anteriorly and don't leave it until they get to the proximity of the sublingual salivary gland, where the postganglionic parasympathetics go and innervate the sublingual salivary gland. So the chorda tympani, at least this part of it, is involved in carrying axons which innervate the sublingual and submandibular salivary glands. Yes?
Is there a sublingual ganglion?
There is no sublingual ganglion. The submandibular ganglion is the only ganglion involved in innervating these two salivary glands. The preganglionic parasympathetics, which did not travel in the facial nerve, that went in the greater petrosal nerve, travel towards the foramen lacerum, where they are joined by the postganglionic sympathetics that were in the deep petrosal nerve to form the nerve of the pterygoid canal. So the nerve of the pterygoid canal is carrying preganglionic parasympathetics from the facial, and the pterygopalatine ganglion, which sits in the pterygopalatine fossa, is another parasympathetic ganglion composed of postganglionic parasympathetic cell bodies. The postganglionic axons from that ganglion do quite a few things. Many of them travel down in the greater and lesser palatine nerves for the mucous glands of your palate. The little brown dot there indicates that many of them travel with these posterior septal and posterior lateral nasal nerves that enter the nasal cavity for the mucous glands of your nasal cavity. Many of them travel back in the connecting bundle to the maxillary nerve so they can enter the posterior superior alveolar nerve, and they can enter the infraorbital nerve, which do mucous glands of your maxillary sinus and the gums of your upper teeth. And then some of them travel in these unnamed branches into the orbit. Those are probably the most important ones, which then do some innervation of ocular arterioles you can read about, but most importantly innervate the lacrimal gland. So the lacrimal gland is innervated ultimately by the facial nerve through this complicated pathway through greater petrosal nerve of pterygoid canal, synapsing the pterygopalatine ganglion, and unnamed branches entering the orbit for the lacrimal gland. And that is the entire parasympathetic functioning of the facial nerve. There are also sensory axons for taste. And there are taste buds in the anterior two-thirds of your tongue, not the posterior one-third. There are taste buds in the posterior one-third, but the facial has nothing to do with them. Facial nerve subserves the taste buds of the anterior two-thirds of your tongue from the lateral lingual swellings, predominantly. So there are taste buds here, and the axons end on them. Then the axons come from those taste buds, travel in the lingual nerve, right past the submandibular ganglion, having nothing whatsoever to do with it, backwards in the lingual nerve, into the infratemporal fossa, and then jump onto the chorda tympani and follow the chorda tympani all the way back to where it branched off from the father or mother facial nerve, and then travels back with the facial nerve through the posterior, then medial wall of the middle ear cavity to a site at the genu where their cell bodies lie. So the cell bodies for these taste sensory axons are located at the site of the genu of the facial nerve. And the ganglion that you find here is called, therefore, the geniculate ganglion. The site at the genu is called the geniculate ganglion. So sensory cell bodies, equivalent to a dorsal root ganglion, or equivalent to the semilunar ganglion of the trigeminal nerve. These are sensory ganglia, not like the pterygopalatine or submandibular, which are parasympathetic ganglia. And then the central processes of these cells, they look like just any other dorsal root ganglion cell. The central processes travel backwards and travel in the nervus intermedius back to the brain where the nuclei for taste are located. And then there are also taste buds in your palate. That's why people are said to have a refined palate, because there are taste buds in your palate. And the taste fibers from taste buds in your palate travel up these palatine nerves to the pterygopalatine ganglion, but they go right through it without doing anything because that's a parasympathetic ganglion. And they travel through all of these nerves we named, backwards in the nerve of the pterygoid canal and the greater petrosal nerve. And those taste axons also have their cell bodies in the geniculate ganglion, and the central processes also travel back through the nervous intermediates. And then finally, a piece of detail that we generally don't emphasize much in this course is the fact there is some actual skin on the inside of your external ear, what's called the inner part of your concha of your ear, which is innervated by a tiny branch of the facial nerve called the auricular branch of the facial nerve, which is given off while it's traveling in the posterior wall of the middle ear cavity. And I'm just showing these somatic sensory axons for touch and pain or whatever else the skin inside your ear might feel. And they also have their cell bodies in the geniculate ganglion. Again, just like a dorsal root ganglion may have visceral sensation, somatic sensation, so does this thing. And the central processes travel back in the nervous intermediates. So this is a really complicated nerve. And they can't get around it. Now, from the clinical point of view, even though it does all of these things, from a clinical point of view, the most important thing that it does is its somatic motor innervation of the muscles of facial expression. This is both true from how you test it, although you can do testing for some of its other functions, and I'll show you a video of that. But the symptoms you get if something goes wrong with your facial nerve, the ones that bother the people and the ones that cause the problem, are paralyses of muscles of facial expression. I remind you, these are not all of the muscles of facial expression that exist. You know that. But these are the most important ones, both in terms of physical exam of the facial nerve and of symptomatology produced. You have a problem with the facial nerve. So there's the frontalis, which elevates your eyebrows, orbicularis oculi, which closes your eyelids. There's a part in the eyelids called the palpebral portion, which just causes you to blink, and a part which sort of surrounds the origins of the eyelids. It's called the orbital portion, which really scrunches your eyes tight, closed tight. Muscles that elevate the upper lip, which we don't ask you to memorize the names of, the levator labii superioris aliquinasi is such a beautiful name for a muscle. It would be a shame if you left here without being able to say levator labii superioris aliquinasi. My professor said that whenever he was invited to dinner and asked to say grace, he would get up and he'd say, levator labii superioris. That's why I love that muscle. There is a buccinator muscle, which is a muscle of facial expression, because that means it's innervated. Those muscles are defined as muscles that are somatic muscles innervated by the facial nerve, but it doesn't really they're not really involved in facial expression. We'll talk about what it does later, but it's in the fleshy part of your cheek. And then the muscles down here, which we do ask you to know the names of: depressor angulioris, depressor labii inferioris, platysma, and orbicularis oris, which closes your mouth tightly. Zygomaticus major, which is, along with all of these elevators of the upper lip, active in smiling and elevating your upper lip and bringing the corner upwards and laterally. The facial nerve, as I mentioned before, enters the parotid gland. It has upper division and lower division, and I remind you of the 5 major branches. The consistent ones are the temporal branch. Zygomatic and buccal sort of are varying size, and they can connect to one another quite a bit. Marginal mandibular, which comes down along the margin of the mandibular, very near the submandibular salivary gland. Deep to platysma, and then the cervical branch, which comes down for platysma. Now, I thought I'd show you this because it's just interesting.
This video shows the salient features of the total parotidectomy procedure. The patient is a 67-year-old gentleman with a squamous cell carcinoma of the right parotid gland. The CAT scan shows a large right parotid tumor with a necrotic center that extends into both the deep and superficial lobes and is abutting the dermis of the skin.
Okay, superficial parotidectomy for mucoepidermal carcinoma. Initially, skin flaps have been elevated two different planes. Upper plane is in a faceless plane with the fat up and fat down. Centrally, you can see the actual parotid gland itself. The silk suture marks where the tumor is, which is very closely opposed to the dermis. The sternocleidomastoid muscle is seen below, which we have not yet detached from the parotid itself. The great auricular nerve can be seen running superiorly into the posterior portion of the parotid gland itself. The superior flap, again, lifted in the facelift plane, and in the inferior flap, lifted standard in a standard fashion in the subplatysmal plane. However, we did have to go superficial here because of the proximity of the tumor to the dermis. Continuing with with what was a superficial parotidectomy, which has now become really almost a total parotidectomy because of the size of the tumor. The flaps have been elevated, and you can see the skin flaps are splayed open in the face and the neck. And what you're looking at here now is the actual parotid gland, which will be elevated with two Alice clamps, so you'll see the undersurface of the parotid gland. Again, the black silk sutures mark where about the mid portion of the tumor is. And now the parotid gland is retracted up, and what you're going to see now, we're going to try to pan in to show the facial nerve. And you're going to see here, we've got the branch of the two branches, the superior division, the inferior division of the facial nerve, and the pes anserinus, which is the nerve coming out of the division where the nerve comes out of the cytomastoid foramen. Okay, finishing with this now became a total parotidectomy, and what we're looking at here first is the parotid removed from the field, and you're going to see the sternocleidomastoid muscle with the great auricular on top. And as you go medially, you're going to see the digastric. That is the facial nerve monitor screaming in the background. Now we're going to show the facial nerve, which was actually had to be peeled off this tumor. And again, you can see the nerve exiting the cytomastoid foramen, the pes anserinus, the superior division, the inferior division, which is going into a buccal branch, and down into a cervical and the marginal mandibular branch. And you can follow that cervical branch all the way down, and that's it. And on the underside, we can also see the carotid artery, right here. Closure.
All right, so I just thought that was interesting because you can see all those things. They really do. You may have noticed that, even though he didn't mention it, that they cut the great auricular. And that's very typical in these kinds of surgeries. You could sort of see it was in a different position when he pointed it out the second time, because they almost always cut the great auricular. Yep.
They were able to preserve all the branches,
It
even though
looked-
it was full superficial.
Even though he said it looked like it was almost a total, looked like to me he was able to preserve all of the branches. You got to get lucky. Probably he didn't, it was not a complete total parotidectomy. Very hard to preserve them in a complete total. All right, so, and then here is someone who needs no introduction.
We're going to move on to the seventh cranial nerve, which is the facial, and it subserves primarily muscles of facial expression. Important to just examine the patient, even while you're taking the history. Is the face symmetrical? Are there any abnormal involuntary movements? A lot of us have facial asymmetry, such as my crooked nose, so it's important not to overcall facial asymmetry until you've examined. So, for the muscles of facial expression, we ask the patient to wrinkle their forehead, close their eyes tightly. They should be able to bury their eyelids symmetrically. See if you can overcome that. You should not be able to. Ask them to put air in their cheeks, and you should not be able to release the air. Show the teeth. It's better to say show me your teeth than smile, because we really want to test this without emotionality being a component. Put your lips together tight. And whistle. Taste to the anterior 2/3 of the tongue is subserved by the facial nerve. This can be tested by using a solution of either salty, bitter, sour, or sweet substances and applying it to the patient's tongue. When doing so, it is important that the patient's tongue be extended and the solution gently applied, and meanwhile hold the tongue so the patient cannot put it in their mouth. Enrica, keep your tongue out and point to how that tasted. That's correct. That was a salty solution. You can then assess a different solution by having the patient have a little sip of water in between to clear the stimulus. Please extend your tongue, and now with a separate stimulus. Now keep your tongue out and point, and that's correct. That was a sugary solution. The reason you don't want the patient to put their tongue back in their mouth is they may masticate and transfer the solution to the other side and therefore give you an incorrect response.
In general, you don't do the taste sensation unless you have reason to suspect something is wrong with the person. And also, I just want to point out to you, do you know the muscle that is involved in puffing out your cheeks? Not buccinator. Orbicularis oris. That's what keeps the air in, orbicularis oris. So she did a second test, squeeze your lips together, which I don't think is actually useful at all. Puffing out your cheeks is useful. If you have, and you, again, you notice how she tried to pry the eyelids open, because you're always looking for asymmetries in strength. You know, people have complete paralysis is not such a difficult thing to notice, but when there's a slight weakness, you want to be able to determine whether one side is somewhat weaker than the other side. So that's why you try and pry the eyelids open, see if one side is strong compared to the other. Same with puffing out the cheeks, and what you should do is, you should do that, and the air should escape in the middle. And if the air escapes to one side, for example, or to the right side, that suggests a weakness in the right orbicularis oris, or obviously if it escapes to the left side, it's a weakness in the left orbicularis oris. So you can actually get a test of strength of the orbicularis oris by that poking the cheeks. Bell's palsy is the most common condition of injury to the facial nerve. It's actually quite a common condition in the sense that you tend to see one or two people like that every year walking around. Especially common here on Long Island because it is a consequence or is somehow related to Lyme disease. People with Lyme disease tend to get Bell's palsy more than your run-of-the-mill person, but it is a condition which is an inflammatory condition of the facial canal superior to the stylomastoid foramen. No one knows for sure what sets it off. There gets to be some inflammation there, swelling, compression of the facial nerve just superior to the stylomastoid foramen. People have been known to just wake up one morning with this. And it is a really unpleasant and potentially a dangerous condition. It is, since it is affecting the facial nerve immediately superior to the stylomastoid foramen, possibly its only effects will be on the somatic motor component of the facial. Here's a person who clearly has paralyzed facial muscles on one side. And the question that you have to answer as physicians is which side? And what is the evidence you have for this? Anyone feel confident? Sir.
Is it his right side? It looks
It is his right side, Dan. Okay. And what is the evidence for this?
well, just he looks more relaxed on the right, on our right, but his mouth's drooping kind of.
His mouth is drooping, so that is paralysis of the elevators of the lip and zygomaticus major on that side. That's one piece of evidence. He has 4 separate pieces of evidence that I can see here. His eye is more widely open. That's called a wide palpebral fissure. You should rarely be able to see the top edge of a person's iris. You should never be able to see any white below an iris. But it's very obvious that this is a normal palpebral fissure with the top edge of the iris cut off, and this usually coming right up to the bottom edge of the iris. So this is a wide, or abnormally wide palpebral fissure. So that's 2. He just yelled it out.
His forehead is increased on the right side.
No wrinkles on his forehead, his smooth forehead on the right side due to paralysis of the frontalis muscle. So that's 3.
The cleft of his lip is pulled to his left.
That's cleft of his lip.
Yeah, like the midline of his lip.
Oh, well, that's actually, I didn't even notice that. But that's a good one. That's 5. Yeah, it looks like the philtrum here is slightly to the left. And I didn't notice that. But since that comes up with 4, even though that's my 5th now, this nasolabial crease is much shallower and less well pronounced than on the side without the paralysis. So the 4 that I was looking for are a smooth forehead, a wide palpebral fissure, a less marked nasolabial crease, and a drooping of the corner of the mouth. Now, if you ask him to close his eyes, it's even equally, now he can't close his eyes. Now, the lower lid did drop some. And the lower lid dropped some because his libera palpebris superioris shut off. And so, it's what's holding it's one of the things that holds your lid up normally. His shut off, but the lid in this particular case is not going to close on its own. And this gives you an idea of one of the real problems. People like this cannot protect their cornea. They have no blinking. So the big danger of a Bell's palsy is ulceration of the cornea. And so people like this have to wear eye patches usually because the disease resolves itself. I guess I didn't give you the good news, did I? The good news is that this disease almost always gets better on its own over the course of a few weeks or months. But during that period of time, if your cornea is exposed like this, then you have to wear an eye patch. Some people are lucky that when they try to close their eyes, the eyeball rises. It's a phenomenon called Bell's phenomenon. When you go to close your eyes, your eyeball elevates. And if you're lucky and your eyeball does that, the cornea might be hidden underneath the lid, and you may not be subject to corneal ulceration. But this person clearly would be, and that would be his greatest risk from a Bell's palsy. Here's another man also with Bell's palsy. He was asked to show his teeth. It's very obvious that he can't do that on the right side. He has no elevators and no depressors, because when you show your teeth, you have to elevate your upper lip and depress your lower lip, and he has neither of those muscles functioning. He also has a very wide palpebral fissure on the right side. And wrinkles in the forehead, not so obviously different. More obvious in this person than in the other person is the drooping of the lower eyelid. It's normally your lower eyelid is kept up against your eyeball by the integrity of the lower part of the orbicularis oculi. And so he's got a drooping of the lower eyelid, and you can see the tears just pool here and come down the side of your face. If your eyelids cannot be held up against your eyeball, then the lacrimal canaliculi don't get the tears as they are. Normally, when you blink, tears are swept from the lacrimal gland downwards and medially towards the lacrimal puncti of your eyelids. And then the tears are drawn by tension, I guess surface tension or capillary tension, into your lacrimal canaliculi and then go into the lacrimal sac. Well, in a person who has paralyzed orbicularis oculi, not only is the upper part paralyzed and the lower part, but a part you don't know about called the lacrimal part, which holds the lacrimal canaliculi up against the surface of the eyeball. Those canaliculi pull away from the surface of the eyeball, and tears pool down in the lower lid and then flop over down the side of your face. When he was asked to close his eyes, he got his eyelid dropped more. You know, some people, when they relax their levator palpebrae scores, the eyelid drops a little, and some people it drops a lot. He probably would be at less risk for corneal irritation than the other fellow was. Now, other things, aside from the risk of corneal ulceration and just the funny appearance that it gives you, that are consequences of a Bell's palsy. And I've broken these into two groups, and you'll see why. Drooling. When you chew and all that saliva is produced, what keeps the saliva in your mouth is the fact that you can close your mouth. If you're chewing and your lower lip cannot be pressed up against your upper lip and close off the mouth, then the saliva tends to come out the side of your mouth and drool down the side of your face when you're chewing. So that's another extremely unpleasant side effect of Bell's palsy. And then chewing itself. When you chew, and this is the function of the buccinator muscle, when you chew, the buccinator actually stays contracted a little bit to stop your cheek pouches, which is the part of your oral vestibule between your gums and your cheeks. It stops food from going laterally and filling up these cheek pouches. In fact, if it contracts too much, then you bite the side of your cheek, which happens to everybody, routinely. If you don't have a buccinator muscle, which can keep the food in between your teeth and stop the food from passing into your cheek pouches, then food eventually accumulates between the gum and your cheek. So people who have a Bell's palsy will either try and chew on the opposite side, but if, sometimes you just chew on the side you're not intending to anyway. If they chew on the side that has the Bell's palsy, the food starts to accumulate, so they're always pushing it up, back out of their cheek pouch in between their teeth again for mastication. So it has an effect on chewing as well because of the role of the buccinator that the buccinator plays in keeping food between your cheeks normally. These other two are symptoms that only occur if the inflammatory condition rises within the facial canal to affect the chorda tympani and the nerve to the stapedius, and that does happen in quite a few people. And in which case, if it affects chorda tympani, I don't know why particularly this is what happens, but it is described, people describe having a salty or metallic taste in their mouth. And it affects the nerve to the stapedius, and if your stapedius is paralyzed, they do complain of things sounding too loud, sometimes even painfully loud. And that's called hyperacusis, when you sense that things are too loud and uncomfortably loud. They also, they also have a problem. You remember when the low frequency components of speech, if loud can mask the high frequency components where a lot of the content is, people who have a paralyzed stapedius have difficulty understanding speech in loud rooms. They have difficulty understanding speech of people who are talking loudly to them because they cannot dampen the low frequency vibrations and thereby improve their perception of the higher frequency vibrations. So those are all symptoms of a Bell's palsy that has risen within this facial canal to involve the nerve to the stapedius. Here's not Bell's palsy. Here's a guy who does not have Bell's palsy. All right, so in this fellow, we know he doesn't have a Bell's palsy because his palpebral fissures are uniform and his nasolabial creases are uniform. But something is pretty odd about him. He's asked to smile, and his smile is clearly not symmetrical. And you might be tempted to say, well, it looks to me like his lower lip is drooping on the left side. But that is not at all what's happened here. In order to make this smile symmetrical, all you have to do is pull down his right lip. What is failing to happen in this person is his right lip is not being depressed when he's smiling. So he has a paralyzed depressor anguli oris and depressor labii inferioris. And that occurs when you have injury to the marginal mandibular branch. You get this asymmetric smile where one side of the lip does not depress. I am not, as you know, I'm not a doctor, and nor do I play a doctor on television, but I do play a doctor when I'm watching television. And this is a diagnosis that I made you will make this too, and you're watching a show, which you have to ask, why is he watching this show called Sewing with Nancy? But I was watching Sewing with Nancy, and at least, maybe, let me say I channel surfed through Sewing with Nancy, and saw her, and immediately had to tape. And she's still on TV, Nancy.
To remove the paper. But as you can see, that paper makes it easy for the stitching. Paper piecing is not a new idea, but the concepts we're giving you today hopefully will give you the confidence to try it if you haven't done that. Many of our viewers have tried this. For example, Karen Wilkes from Park Forest, Illinois, has a tip for paper piecers. Her advice is when you're doing foundation piecing, unless your quilt is truly a scrap quilt, she suggests to pre-cut the strips to the approximate width before stitching them to the foundation. She writes, otherwise the waste can be incredible, the waste of fabric. We just used a very simple design, but in upcoming programs I'll give you more detailed design.
It's very clear that this woman has a tremendous asymmetry in her face. And again, you're tempted to say something wrong on the left side. Her lip looks to droop, but it isn't that at all. It's what this other fellow just had, which is she's unable to depress the right lower lip. Actually, some students in the past have said they thought that her nasolabial crease was a little less prominent on the right side as well, which would suggest maybe a lower division, not just a pure marginal mandibular. I wasn't sure of that, but it's very obvious that she does have paralysis of her right depressors of the lower lip. Yep.
It also looked like her right lower eyelid was a little droopy.
See, now that's it. People are seeing things in this.
It says on Wikipedia, which is an online encyclopedia, that she has Bell's palsy, and she called herself the poster child for Bell's palsy.
She doesn't have Bell's palsy.
Yeah, she does.
I want to tell you that Wikipedia is not the same as the Encyclopedia Britannica. You know why I don't think she has Bell's palsy? Because her palpebral fissures were intact. She may have had an unresolved case of Bell's palsy, but only left that all the upper half of her muscles were fine. You want to know something? Now I'm looking again at this and wondering if is her right eyebrow elevating properly?
Like a news article, she talks about it.
Yeah, no. I mean, but you know, to me, the upper half of her face had always looked normal, but now that you mention it, her right eye did not look wider to me, but maybe it looks right to you. But when I'm looking at her eyebrows, it looks like she might not be able to elevate her right eyebrows. In which case, Wikipedia will be right and I will be wrong. You may recall that the conversation, today's Wednesday, the conversation Monday ended with Chirag challenging my diagnosis of Nancy Zeman because I had supposed or suspected that it was a marginal mandibular. Then I said, well, maybe it's an inferior division of facial nerve because I never saw anything going on with her upper face. And Chirag's challenge was based on this newfangled thing which I'd never heard of called Wikipedia. And from the Wikipedia page is this statement. I assume this is the one that he read. Zeman, that's Nancy's last name, has Bell's palsy and is open about her condition. Having written about it, been interviewed by journalists, and hosting a segment on a TV show with professionals, she jokingly refers to herself as a poster child for Bell's palsy. Now, my response to Chirag was, you can't rely on this. Now, let me state that one thing is absolutely true. I was wrong about what happened to her. But we'll see whether I was wrong about my statement about Wikipedia. One of you in the audience, too, and I don't know if it was you, Jill, or someone else, who said you thought you could see a drooping of the lower eyelid on the right side. This is a picture I grabbed from the web. And it does look to me a little bit like this is drooping, but certainly not her upper eyelid is not too elevated, in my opinion. It looks equally elevated. You can only, in fact, you can actually see a little white right here. beneath her iris in this picture, which you cannot see on the left side. So that is further confirmation that I was wrong, that her problem does involve more of the facial nerve than just its marginal mandibular or lower division. Plus, I went and I found this other thing you probably never heard of. It's called YouTube. If you watch her left eyebrow compared to her right during this. It looks to me like her left elevates from time to time and her right does not.
Hi, I'm Nancy Zeman, inviting you to the 3rd Annual Quilt Expo in Madison, Wisconsin. You're going to love this event. It's one of the country's most exciting quilting forums. You'll find workshops, hundreds of spectacular quilts on display, great shopping opportunities, and much more.
Now, I thought it did, but you see though that she's able to lower her eyelid pretty well.
And much more, and much
And the possibilities are, in terms of why she might be able to lower her right eyelid, is number one, her eyelid just, when she relaxes her levator palpebrae superioris, her eyelid just lowers well. The other possibility is, and you can search this out, you'll see Dr. Degum will mention to you on Friday, in some people whose eyelid does not lower well when they relax their levator palpebrae superioris, who have this condition, they put a little gold weight in the eyelid to give it some extra weight so that when you relax the levator, the eyelid will close completely. This is not generally in a Bell's palsy condition. I don't know whether she has this or not. Maybe you can find this out by searching. This is the definition, by the way, of Bell's palsy. From a book written in 1985, but the definition holds true today as it did even before that. It is a facial paralysis of acute onset, presumed due to a non-suppurative, that means no pus is formed. Non-suppurative means no pus, no. A non-suppurative inflammation of unknown etiology of the facial nerve within its canal above the stylomastoid foramen. And it is furthermore often called, and this is a more modern textbook, spontaneous idiopathic facial paralysis. Idiopathic meaning no one knows what causes it, all right? But the issue of whether Wikipedia was right or not was brought to my attention by Bryce Schroeder, who put me on, was Bryce, are you in the room? Yeah. Who put me to a different website. She was told that her facial paralysis resulted from an ear infection. She was 1 year old when this happened. From the same otolaryngology book, the intratemporal complications of otitis media, that's what an ear infection is. Hearing loss, vestibular balance problems, acute perforation, these are not all, but these are possible ones, and facial paralysis. So the question I ask you, is she correct, and is Wikipedia correct, in that she really has Bell's palsy, which is an idiopathic condition that occurs spontaneously, or did she really have an ear infection when she was 1 year old, and that ear infection eroded through the bone of the labyrinthine wall of the middle ear and affected her facial nerve? So it's possible Wikipedia still is wrong, even though I was also. Yes?
You mentioned that Bell's palsy resolves itself in a short period.
In most people, I mean, actually, when you read the webpage about her, it says her Bell's palsy didn't resolve itself. In almost everybody, it does resolve itself.
But facial paralysis?
But facial paralysis due to damage to the facial nerve by middle ear infection will not resolve itself. That nerve is damaged by the infection, having eroded the bone, and you know that the facial nerve travels in the medial wall. Yes?
We checked after class, and Sylvester Stallone did have a damaged facial nerve.
Oh, yes, that was another race. Sylvester Stallone, I still have no mental image of his face, but people who know him well apparently would say he does have a facial nerve problem.
His mother had problems delivering, so they had to use forceps.
Oh, they had to use forceps. They must have put it behind his ear. His mother should have sued them. This is another guy, named Roger Ebert. He was an extremely successful and well-known movie critic. He still writes movie reviews.
Hey, recapping this week's movies, a big split on Van Helsing. 2 thumbs up for A Foreign Affair. We split on Seeing Other People. 2 thumbs down for New York Minute. 2 thumbs up for Valentine, and we split very big time on the saddest music in the world.
So here's another case where you can see that the right side of his lower lip isn't coming down. Now, when I first saw him on TV and saw this, I then did my own Google search. What is wrong with this guy? Because I had my own idea that it was a marginal mandibular nerve injury. And you couldn't get any detail at that time. They said he had some tumor of a gland in his neck, and he had some surgery on a gland in his neck, and that accounts for his left lip drooping, which was completely opposite of what I thought. So I continued to watch the show looking for the one thing that would give it away as to what was really wrong with this fellow.
You've never seen anything like it. I would agree with that. But I'm going to give it thumbs down because I don't think it holds together.
Ah, did you see anything? Here's that. He's had surgery on his submandibular gland on his right side. That's damaged his marginal mandibular. Sadly, he's had many surgeries since then because they haven't been able to control it. He hasn't been on television in many years, I don't think. But you can, it goes to show you, with the knowledge that you've learned in this course, not only be as good a doctor for television personalities than me, but a better doctor for television personalities than me. All right, so that's it.